within 48 hours, so there's always time to involve
Take the
parents.
2 hours out. Right.
Okay, so welcome to everyone. Thank you for joining Primary Treatment Modalities. This is just a basic review of the applicable treatment approaches that we've been talking a little bit about for crisis center work. But again, we want to relate this to the chat process and what we might see in chat exchanges that reflect some of these techniques and approaches and theories. So this is just going to be a basic review. I'll go through the material, and then, of course, as I said, we'll have a chance at the end. We can go until 4:15 if needed, but I realize that that might not work for everyone. But we'll certainly take this as far as we can to make the most of the time. But I will move through the slides at a relatively quick pace to keep it going and leave some room for dialogue, and hopefully we can end close to 4. So let's just look at our objectives. I have, of course, sent these to you in an email. This came up, and I know that this was rather sudden in deciding to do a webinar, and even though it's a webinar, it's still informal. I just thought it might be a good opportunity to take now, since we've been discussing some of these short-term treatment modalities that are often applied in the work that we do, and I know that some centers thought it would be helpful to identify what actually is happening in the chats, so you can feel a little bit more grounded and confident and clear. But again, this isn't intended to teach everything through and through, of course, and none of us are expected to be experts in any of these particular treatment types. So this is not to burden anyone. This is just to enhance. And I know that many of you already have a lot of this fundamental knowledge and experience. Many of us are clinicians or have been therapists previously, working with different types of clients in an individual or group setting, of course. And this is not treatment that's being done, whether it's on the phone or chat or text, but although it's not treatment, it still falls within a treatment context, and we're always applying some type of tactic that we want to be reflective in these types of skills that seem to work best with the different people that reach us, whatever the medium happens to be. So definitely keep in mind some examples as we go through this. I'm going to touch on some short-term crisis intervention concepts that are relevant, and then some basic cognitive behavioral techniques, and then some basic DBT techniques, as well as a little bit of solution-focused treatment, because I think those are very relevant. In the future, we can perhaps look at motivational interviewing, but I didn't want to be too ambitious for this. So crisis intervention, of course, that's one of the core things that we are doing on the phones, but also in your chats. And that does not mean that every single chat that your centers are receiving is a crisis. It can vary on the scale, as we know. But in general, if it does seem to be a crisis based on what the person is expressing, what they're reporting, and of course this is according to their experience, which we always respect, we want to be aware that we're trying to engage as quickly as possible and assess the situation based on what you're reading as quickly as you can to see, well, what's the immediate concern here? This is often most appropriate for someone who is facing a particular stressful event right now, and that's really going to be what the chatter tells you, right? What is causing them to be in such an uncomfortable state. And so for them, regardless of what is occurring, it could be considered a crisis. Then we really want to look at how can we stabilize this individual for now so they feel a little bit more emotionally grounded and less uncomfortable. So that's the idea in this exchange, in this context that we're, of course, looking at with chat. Basic needs. What's the practical situation right now? What needs to be addressed at this time that's most important to the chatter? Because that is really where we want to start. Keeping it concrete in crisis intervention, whether we're, of course, on the phone or in chat or text, is important. We're not going to get too exploratory or abstract, right? And the idea here is to always balance between a supportive yet direct approach, because we might really have to ask some specific questions, especially if we sense something a bit more imminent in getting that assessment done, but still being supportive and accessible, so to speak. Now, short-term or brief treatment, that is the framework that we're really all working within. So again, it's not always what we might consider a crisis, or even the person chatting in certainly might not feel that it's a crisis. However, they're in need and they want to reach out, and we want to support that. So with short-term brief treatment, and again, this is not treatment, but it is the framework that we are working from, because it is a very brief exchange. So even if it's just that one time that you are chatting with the individual, that's the opportunity that we have to build that rapport, connect, and see what we can assist with. For instance, keeping these concepts relevant to short-term work in mind, we are, of course, identifying new and improved coping skills with this person. That's really the goal, to cope in the moment. We're looking for short-term symptom relief for this person. Doesn't have to be clinically identified symptoms, just whatever it is that they say. Maybe they feel that they're just going crazy, so to speak. We're going to work with that. How can we help them feel less crazed at this point in time, less overwhelmed? We want to look at whatever the concrete goals might be, and we always want to build that in a collaborative way, motivate that individual toward the change of the moment. Focusing, again, on the present. Keep it reality-oriented. We don't want to get too abstract if it seems that that will lead us in a roundabout type of situation where we're not staying focused on the issue at hand, and we want to help the person identify the key issue, what they want to work on for right now. What's the priority? So again, it's symptom reduction toward behavioral change, but we are not here to perfect someone's behavior. We're not, of course, going to tell them that that's the wrong type of behavior, but if there's something that we can support them in working towards a longer-term goal that would be appropriate to explore in a treatment setting, well, great. We just want to help that person feel a little more comfortable in the moment. It's a more active approach, less passive. We're not wanting to sit back and just say, yes, I got it. Now, not to say that that doesn't happen, but I believe that in the chats you're more active in your responses, obviously, especially since you don't have the sound. You don't have those audible gestures to offer. You have to sort of be a little bit more, have a little bit more to respond with in what you type. And I have this here in terms of the short-term brief treatment concept. Keep termination clear. I have that there for a reason. Again, this is not a treatment situation. This is not a therapy session that's happening exactly. However, termination is always relevant, and from a clinical perspective. The fact is they're reaching your center via chat. You're engaging them. You're encouraging. You're aiming to motivate them toward something that will improve their current state. Yet this is an ultra short-term situation, literally, right? Whether it's a few minutes or up to an hour, depending on what's happening with this exchange, it really is intended to end. And that needs to be clear, even if it's conceptually clear, has to be clear on both sides. The chat visitor and, of course, the chat specialist, recognizing this reality, that this chat does need to, of course, come to an end. We come to an understanding, we summarize what's agreed upon, we end it, and move ahead. So those closings of chats are really just as important as the opening of a chat, obviously. Same thing with our calls. So let's look at CBT, cognitive behavioral therapy, because this is one of the primary modalities, as we know, in that short-term brief treatment framework. It's applied in many different ways. Does not mean that CBT cannot be applied in a longer-term treatment setting, it certainly can. But we're, of course, looking at it as a very action-oriented, goal-oriented, concrete process. This quote here, "There's nothing good or bad, but thinking makes it so," kind of sums up the concept of CBT as we know it. And let's get into that a little bit at this moment. The fundamental principles. The idea here is that our cognitive activity, what we're thinking, affects our behavior. And that cognitive activity and behavior, it's believed, based on this theory, can actually be monitored and altered if someone is willing to do so. The desired behavior change that is identified between whether it's client or therapist, or in this case, of course, chat specialist, whatever that behavior change, and again, this could be very, very small, it's really achieved through a cognitive change. And again, we are not doing any permanent rewiring here in our calls or chats, but at least we can get something started to help the person realize that they can see their situation from another angle. Now, CBT is the most, probably, I believe, the most frequently endorsed, empirically supported type of treatment. And just to give a little background, since we're focusing on this, it is rooted, as some of you, of course, have studied, in the work of Alfred Adler back in the 50s. And now Beck was someone who developed the cognitive therapy concept, which is subtracting the behavioral component. But we really look at this as a hand-in-hand thing between the cognitive activity and behavior, as I just said. So the idea is to address what's going on currently that seems to sustain whatever those self-defeating modes of thinking happen to be that lead to a behavior that proves to be somewhat problematic for the individual. It's not about, again, exploring past causes, and really it's not getting into the analytical aspect of that. That's for, as we know, a longer type of treatment commitment. So the cognitive portion does seem to emphasize that Socratic type of questioning that you may have, of course, heard of, which involves a series of questions that helps an individual simply reevaluate the logic of his or her thinking. So we don't want to confront and say, that's completely wrong.
Completely
Why
wrong.
do you think that? We want to just be able to include and invite a possible alternative to how this can be viewed, because we don't always know everything for sure. We like to make a lot of assumptions, and I think we all know that saying about assumptions that can get us into a little trouble. So we just want to broach that carefully with the individual. So again, the idea here is with CBT, just to appreciate it a bit more, is that early experiences often shape what is believed, what our core beliefs are, and we're not about to go backwards and fix any of that for anyone. That would be nice. There is that cognitive/emotional map that starts very early and it becomes internalized, and that really is the template that we're all working from for our current and future thinking. So that naturally, again, affects how we behave, but also how we react to others, how we interrelate, how our relationships play out. So there's a lot of meat there to chew on. We don't want to delve too deep in these exchanges on calls or chats, yet we do want to feel that we can show this person that it might make some sense based on past experiences, that they have these certain views and ways of thinking, but that if they are open to a new way of looking at the situation, it might yield a bit of a different result, and maybe they're open to exploring that. Because the reason for that is this last bullet, the environment, whatever they're surrounded by, whoever, whether it's just simply exchanging a chat with you or your specialists or their therapist or their friend or their family or their roommate, those people and those experiences and what they're surrounded by can actually still have an influence. So we want to take advantage of that. None of this stuff has to be set in stone. So we want to help make that clear a little bit. Just to say a little bit more here, so belief, when we say that, we're again, it's about the thoughts that we tell ourselves. I'm no good at this. I shouldn't be here. I don't, no one likes me. That's negative self-talk. Obviously, that leads to a feeling of, I feel like a loser. I feel that nobody likes me. I feel that I'm useless and worthless. I feel, therefore, depressed about it. And then that, in turn, results in some type of action or behavior. Well, because I'm worthless and useless, I might as well not even go to school today or work. Might as well stay in my pajamas and do nothing. And that, of course, we know can create a pattern. Albert Ellis is the person that took CBT a little bit further. He developed this rational emotive behavioral therapy, REBT, and he came up with this ABC model. REBT is an action-oriented approach to manage cognitive, emotional, and behavioral disturbances. So it's really the same thing of what we're discussing, and there's no need to get too preoccupied with these distinctions and identifying everything so specifically. But just for the value of this, I wanted to point this out, that he came up with this ABC model. So another way of understanding this is that an activating event has occurred, a trigger that has created the person to think about something in a certain way, tell themselves something that may, of course, be negative, which can cause a certain outcome or consequences. And those consequences are what they end up feeling and then doing. So oftentimes, I believe we hear through those who reach the lifeline that something had occurred. Their boyfriend broke up with them, their boss yelled at them, or their teacher yelled at them, or someone at school was picking on them today. Therefore, they have this reaction of feeling, thinking, and acting out. So that's just another way of understanding this concept. So the basic things to keep in mind of what we're really hoping to do, and think of this again in the broader context of this type of modality, but then boil it down to this finite, ultra short-term experience of chatting with someone, and then think of some examples when we get to that point in this call about how this seems to play out. Are there times in a chat that you are finding that clear identifying of concrete goals? Or goals, doesn't have to be more than one. What is it today that you would like to get some help with? Now, in the theory of this, you're going to track treatment progress to learn from this person's behavior so the individual, the client, can learn as well. That's not as applicable here, but it's still relevant to understand. And then if this person was in treatment, we'd want to provide assignments so they can actually practice a different way of handling a situation that often creates some problems for them. But you might even come up with some assignments, so to speak, on a chat, offering some ideas to process emotions, and we'll get into some of that in a minute. And then, of course, we really, again, want to develop these cognitive and behavioral coping skills that can actually be exercised. So in a treatment setting, you have that opportunity week to week to provide these assignments and then come back and report, well, how did that go? Show me what you wrote down. And we have some examples coming up in a minute about what that might look like. These types of approaches can include what you see here, exposure techniques, getting the person to agree to face what it is that is disturbing them. I'm going to just use a social example about feeling like the person is not accepted, for instance, and being invited to a party and just feeling that nobody really wants them there even though they're invited. But right there you have an inconsistency that can be pointed out and say, well, it seems that they invited you. But that might lead us to assume that they want you there, and to kind of point that out. But to say to the person, well, the next time you're invited, can you actually go to this party and report back how that works? So that's an exposure technique. Cognitive restructuring is another method. Again, that's pointing out some inconsistencies. And then relaxation techniques such as visualization, meditation, deep breathing, very basic things that you can suggest to someone. In a treatment setting, you might actually do this with the person, but obviously in a chat, not that you can't be side by side with them, so to speak, but you might just offer some of these suggestions to count to 10 before acting, to take 3 deep breaths and breathe out, through the nose and then breathe out slowly through the mouth. Sitting still, ask them if they can do that with you, if you think that they're really in a heightened state of distress. And then, of course, the social skills training, which might be tied to the example I just gave about going to a party and practicing what it's like to just show up and say hello to 3 people and see how that feels. Okay, so we have the fact that this is effective with a variety of types of people, and we have, of course, those suffering with substance abuse, depression, anxiety disorders, phobias, obsessive compulsive disorder. So there's a variety of things here that CBT seems to be helpful with. Again, it's not saying that there aren't other methods that are also very effective and useful, and sometimes it's really your instinct of what's going to work for that person right now. So let's just always keep our gut in mind there and trust it a little bit. The homework and the exercises and the assignments that I was referring to a moment ago, here are some examples that might fit. Often these are things that are applied in CBT treatment. Again, it's very active and concrete and collaborative. So the therapist in the treatment setting is very involved and not just sitting back passively listening and nodding their head. That might be helpful in some regard, but in really trying to identify problematic or self-destructive, self-defeating thinking that leads to what's reported to be unwanted consequences or outcomes, then we really have to get more concrete and be involved and walk the person through some of these types of things. So journaling, as we know, is very common, suggesting, why don't you list some of these activities that you like, list the ones that you don't like, and then check off how many you did that you like versus how many you didn't like, and how does that balancing out? Are you doing too many things that you just don't like, and is there a way to adjust that? Sometimes seeing something on paper can make a difference. We already kind of talked about assigning of activities, such as going to a party. Go to that why don't you go to that party this weekend, and then let me know how it went next week. And even if you just go for 1 hour, can we agree that you'll give that a try? So there's some cognitive rehearsal involved as well. You imagine that situation with the person that you are working with. So that you might do this on a chat and say, well, tell me a little bit about what it might be like for you to go to that party. And then you can ask them, well, and what do you think about that when you imagine it? What do you think about yourself? And they're going to tell you, well, I think that I'm going to embarrass myself. I think that I'm just going to be someone that people laugh at when I walk in. And then, well, let's imagine that to be the worst scenario. What can you do if that happens? If people do happen to laugh at you, what can we plan for right now together? That's just one idea. This triple column technique is something that can be helpful. Again, seeing something on paper, identifying in the first column, what is this distressing event, such as going to a social event? Then what results in that emotional reaction and what you tell yourself? Oh, I tell myself that nobody wants me there. I'm just going to be laughed at. And now in the third column, well, let's come up with another way to think about that. maybe people will be happy to see you. Is that possible? Maybe one person out of the 20 people there could be happy to see you, and then write that down and see how that might influence the individual to respond a bit differently and have a different experience. Because if they can have a different experience, they relearn and they have something a little bit remapped, rewired to believe that, oh, it's not always that horrible reaction that I get from people. It's actually not that way all the time. And I can feel a little bit more comfortable going to these types of social events in the future. We all are very familiar with the safety plan, so I'm not going to get too focused on that. But that can definitely be something that's worked on together as an exercise to have that person hang on to it and refer to it on their own. Okay, let's look at our dialectical behavioral therapy, DBT, because I know that's what came up. That's what came up with I think our last call, and this is one of the reasons why I figured we might as well cover some of this material. So it is a modification of CBT, which is why I started with CBT today. It is, well, first, let me say a couple of additional things. The word dialectical is really just referring to a conversational type process of resolving differences between two different views. So it's just speaking to that exchange of questions and then taking some information and helping to bridge two different views so it doesn't have as much conflict. This was originally developed by Marsha Linehan in the 90s, and it was really something she designed stemming from CBT to treat mostly women with suicidal or self-harming tendencies, that self-directed violence that we've been talking about that might be different from an actual suicide attempt, as we know. Two distinct things that can seem quite similar. She had discovered that a lot of her clients were responding to the typical CBT approach with withdrawal and anger and frustration. Often she was dealing with those females mostly, again, who were suffering from certain borderline personality disorder features. So she had experienced that they just weren't taking to that in the way that she was originally applying that CBT approach, because it really, CBT emphasizes change a lot, whereas with DBT it's less about telling the person to change, or at least it's less about even asking them what they want to change. It's more about self-acceptance, getting them to accept what they feel that they are and letting that be the starting point. So what you see here, of course, it's mostly to address self-harming behavior, that emotional vulnerability and sensitivity that comes through, the invalidating environment, feeling that nobody accepts them. There's often those that back and forth of those who they can say are the only ones they can trust, and then those that are absolutely not to be trusted. So it's trying to find a more validating environment for the person, so they're not fluctuating to such a degree. And we want to help them cope with and manage those intense surges of emotion so it doesn't take them over, and finding ways to accept that that's how they're feeling, that it's okay, and that there's actually a way to manage it so they're less overcome by it. The techniques of DBT can include what you see here. There are very specific techniques applied that a DBT specialist should always be trained in. This is a very precise approach. CBT, I know it's hard to hear the differences on this phone probably, but cognitive behavioral therapy can be applied a little bit more flexibly in its concepts, which is, of course, again, what we're talking about here in the work we do via phone and chat, etc. Again, this is not applying treatment in its pure form, but it's reflective of it. So, but just to keep in mind that dialectical behavioral therapy is intended to be applied much more specifically and in a much more structured manner. It usually lasts about a year, for instance. A very set schedule is laid out. Not that that can't be done with CBT, but definitely with DBT. And it really does require that the person in the treatment is motivated and voluntarily participating. So not everyone is really appropriate for it. So it's a little bit more specialized. I just wanted to make that distinction. So when we review this, we're not looking to actually be conducting DBT in a chat. It's more just recognizing that when we take certain approaches in engaging the person and how we are looking to support them and offer some comfort to help them move on, that it might actually be tied to this theory and practice. So again, it's behavioral skills training, the cognitive modification, really thinking about a contingency plan is needed for these situations that might arise where they feel out of control. What's their backup plan? Who can they call, etc. And then really practicing that exposure to certain emotional cues, because the emotional crisis is often what we're dealing with. So we hope to build skills in the following areas. And again, this is not to say that you're going to build these skills in one chat, obviously, but keeping this in mind, ultimately we would hope that ongoing treatment could help someone with their interpersonal effectiveness, especially in conflict situations, because a lot of people that end up in DBT treatment really don't respond well to conflict, which is why we want to have a careful approach in engaging them and staying as aligned with them as possible when we sense that they're sensitive, because they'll just hang up on us, right? Or just exit the chat and basically be like, forget you, you're not on my side. So there's this automatic assumption of me against you, and that's what we want to help dissolve as best as we can. And again, it's regulating those painful, uncomfortable emotions in a way that this person can end up not getting too stuck, because then they become paralyzed, being so fixated on this uncomfortable emotion that we're feeling. And then, of course, that involves tolerating this. So how do we keep it under control, but then how do I literally live with it and accept it? That's really an important aspect of DBT. Another important part is this idea of mindfulness techniques. It's a different from meditation. And of course, there's different types of meditation, and we don't need to break that down. But just to point out that with DBT, the mindfulness aspect of it is to help the individual be in the moment, recognizing everything that they're feeling and thinking, and just acknowledging it and living with it and tolerating it and just experiencing it, because we can't take that away. We can't change it. It is something that needs to be faced, but to show them that they actually can do it and that it will pass, whatever this type of emotional pain is right now. It might not go away entirely, but the intensity of it will subside to some degree. So practicing that tolerance is often done through a mindfulness process, which again isn't going to happen on a chat, but it's something to just be aware of, because someone might tell you that they've tried this already. And you can certainly support that effort. So the approach is very much a balance between encouraging the person, being supportive, of course, and then validating. There's a lot of validation that's needed often with a DBT client. But again, still pointing out inconsistencies as they are noted in what somebody is telling us, because that's usually the key. When we can point that out to someone, it's kind of hard for them to deny it. They may ignore it, but they'll recognize that is indeed a bit of an inconsistency, even if they don't want to acknowledge it. But that's okay. It's something for them to think about. And again, DBT differs from CBT in that the focus is not so much, especially initially, it's not on behavioral change. It's very much about the emotional tolerance and self-acceptance of those feelings. So that's just something to keep in mind working with those that seem to have a certain emotional distress to a degree that they are exhibiting particular